Yeah, good afternoon or good evening, good morning from wherever you are joining. A very warm welcome to another episode of our CytoSorbents webinar series. My name is Dr. Volker Humbert. I'm a member of the medical team of CytoSorbents Europe, and it's my pleasure to present you today a general update on CytoSorb therapy in critically ill patients. So without further ado, I will start sharing my screen. This presentation, I hope you can see it. This presentation will roughly last about 35 minutes. I encourage you to ask questions if there's anything unclear via the Q&A section. I'm supported by a colleague of mine, Dr. Klaus. She's also a trained anesthetist and intensivist, and she will support me with answering your questions. Alternatively, we can also discuss one or the other open question after my talk. The rough agenda is as follows. For those who are not that familiar with the product yet, or who might join this webinar for the very first time, which is of course great news, then I will briefly present the adsorber, then show some data that technically the cartridge does its job, it's working, it's there to remove cytokines. However, to make a clinical impact, it's very much important to have a proper therapy management. So patient selection, timing, dosing. I'll share the current best practice in this regard with you, then some recent clinical data, and then a final summary towards the end. Let's start with the adsorber. When we speak about CytoSorb, we first of all speak about an adsorber. We don't speak about a filter. There's no membrane in the cartridge. The cartridge contains highly biocompatible porous polymer beads, rather small, and a very porous structure. And this results in a huge adsorption surface, which is quite attractive to hydrophobic substances. So those substances can build adsorption interactions. They can stick to the surface and are thereby removed from the blood. However, only if they are small enough to enter through the pores on the surface. So there's a size selectivity given with a threshold at around 60 kilodalton. This is also a safety aspect because this threshold kindly excludes important substances like albumin or coagulation factors, immunoglobulins from relevant removal. Last but not least, there is also a concentration dependency. This is another very important feature of the removal provided by CytoSorb. This is a kind of auto-regulation, providing a high removal efficiency only in the elevated concentrations. And this again is a safety aspect because it prevents a complete removal from physiologic mediators from the blood, and it's supporting the principal target of using CytoSorb in critically ill patients. And the principal target is to restore balance. We know that health can be defined or can be seen as a balance between antagonistic forces. So our organism is very much interested in keeping a strict balance. Levels of substances are tightly controlled and corrected. However, sometimes this isn't working properly and a severe imbalance is occurring. And so it's important to restore this balance as soon as possible. One way to support this is CytoSorb, and in a way it can be seen as a complementary technology to dialysis because it removes a broad range of substances that is not removed or that are not removed by conventional dialysis. We know that dialysis is a kind of support of kidney filtration. It focuses on the water and the water-soluble substances. In contrast, CytoSorb is kind of supporting liver and kidney excretion to some extent and is focusing on mid-sized molecules and hydrophobic substances. So exactly those that are not very well removed or not at all by conventional dialysis. Similar to dialysis, you of course need an extracorporeal circuit. However, if any circuit is present for other reasons, you can easily integrate the adsorber into these circuits. So integrate CytoSorb into a renal replacement therapy circuit, into cardio-pulmonary bypass, or into ECMO. However, if no such circuit is present, you can also use CytoSorb in a standalone approach in a hemoperfusion-like setup. I will share this aspect in a few moments in a bit more detail. The blood flow allows a large range from 100 mL per minute up to 700 mL per minute, and the adsorber itself is compatible with systemic heparin as well as regional citrate anticoagulation. From an official point of view, you have 4 substances or substance groups as a target for rebalancing, as a target for removal in case of elevated concentrations. And this is cytokines, bilirubin, myoglobin, and the two antithrombotic substances, Ticagrelor or Rivaroxaban, when the adsorber is used during cardiopulmonary bypass. The target substance leads to various clinical indications like vasoplegic shock, ARDS, or hyperinflammatory conditions like HLH or cytokine release syndrome, the field of transplant, as well as cardiac surgery, or other potential fields of use. This list is, of course, not comprehensive, just gives the currently major fields of use in this setting. There are other targets. They will be discussed and presented in dedicated webinars to come, or were already presented in the webinar of last week by my colleague when the focus was to show approaches in cardiac surgery. So I will concentrate on the cytokine removal and the clinical indications in this regard. And I would like to start with asking, where are we? As this was also nicely discussed at the recent ESICM Congress in Milan. There was a nice discussion between Michael Ioannidis from Austria and Marlies Osterman from London on extracorporeal therapies in ICU. Where are we with the evidence? And Marlies a couple of times stated quite nicely that it's about approved therapies with a great potential. Technically, the cartridges work and they are being used. And I think it's more than fair to say that this is also very much given for the CytoSorb adsorber. There are a variety of data showing that CytoSorb is doing what it's claiming to do, namely cytokine removal. Quite old studies have shown that via the adsorber, effective IL-6 removal was given. Large RCTs in the setting of cardiac surgery have shown different plasma levels in the CytoSorb treated patient group in comparison to control patients, and a prospective single center study showed a very nice and impressive reduction of IL-6 levels under CytoSorb therapy. But for those who are still a bit in doubt or uncertain, I think the final proof of principle, the final confirmation was given this year in spring when Professor Peter Pickers presented his results also at the ESICM Congress. He had done an experimental setup and could show that CytoSorb markedly attenuates circulating cytokine concentrations during systemic inflammation. In this setup, there was an LPS challenge to trigger systemic hyperinflammation, and you could show that those that were treated with CytoSorb had a by far lower cytokine levels. The areas under the curve were reduced by up to 70% for IL-6, for example, or more than 50% for TNF-alpha. So effective attenuation of elevated cytokine levels was seen. There was a second challenge, which also nicely showed, again, a safety aspect, because there was no any negative influence on immunocompetence in those that had been treated in the first challenge with CytoSorb. So I think quite a nice final confirmation. The cartridge works, it does its job, and it seems to be a very safe approach to do so. Last time in July, on the most recent update in critical care, also showed you some first data on the fact that there are other proteins to be removed by the CytoSorb and not only cytokines. So this is a result from an investigation from Halle in Germany, resulting in the presence of quite some damaging proteins that were kept when the adsorber was used in hyperinflammatory conditions. So the authors concluded that hemoadsorption allows a broad spectrum removal of a wide range of molecules, eliciting endothelial damage. And we know that the endothelium is very much in the focus of hyperinflammatory conditions. The endothelium has very much a regulator role in regard to vasomotor tone, but also in regard to inflammation and coagulation. And it's very much damaged in this condition. So endothelial dysfunction is a crucial problem, as this is lying the base or providing the base for microcirculatory failure, and last but not least, then organ failure. So the idea that maybe also some damaging molecules are removed is also supported by this quite recent abstract that was presented in Weimar at the sepsis update in September. Also here, marker, strong endothelial damage marker was found in the blood of septic patients. And this marker was not only found in the blood of septic patients, first of all, it was found in the CytoSorb adsorber, when again the cartridges were examined. So there's more and more evidence, more and more signals that CytoSorb is providing more than just removing cytokines. So potentially this is leading to speculating whether endothelial dysfunction can be impaired, prevented, so endothelial integrity can be improved, which of course, if true, would mean quite a market kind of revolution or a very important aspect in the therapy of sepsis and septic shock patients. This paper coming from the group of Sandra Lindstedt on the field of transplant also suggests that there's a lot more than cytokine removal happening when you use the adsorber. They could show via quite sophisticated analysis, they did some gene set enrichment analysis, they could show that there are quite some proteomic changes happening when you use the adsorber. So there were quite some differences in the gene sets between the treated group and the non-treated group. And they conclude that the study demonstrates that the consequences of the treatment, so the consequences of CytoSorb treatment, can be a lot more expensive on the immune system and its associated pathway than it would be if just cytokine removal would be happening. However, it's fair enough to still ask the question about what's the clinical relevance. So does this translate into any clinical changes? And I think here again, coming back to the discussion between Michael Ioannidis and Marlies Osterman, she made a very nice comment as well by stating we have to learn how to apply those therapies. We have to learn about patient selection, timing, dosing, because as with every other therapy, this is of course very much important. The cartridges work technically, but they have to be applied in the right way to make a clinical difference. And if they're not applied in an optimal way, so if it's a rather unselected patient population, or there's a certain delay, too long of a delay since until CytoSorb is started, or the dose is not appropriate, that this might also confound the effects of CytoSorb. So this might explain studies that could not show effects of CytoSorb in the setting. I think it's important to know that this is not meant as a criticism against the author. This is just reflecting that we have a certain evolution and a better understanding, a by far better understanding on what the best practice therapy management should look like as we had 10 or even more years ago. So let's share some thoughts on decisive aspects for a clinical therapy like CytoSorb. Let's share some thoughts on patient selection, timing, and dosing, but starting with an even more general statement, keeping in mind that CytoSorb is an adjunctive therapy. So CytoSorb is not meant to replace any standard therapeutic measures. It can't also be any causative therapy. CytoSorb is an add-on to the standard therapy in those cases where a rapid stabilization of a patient is not working solely with standard therapeutic measures. And then it's time to specifically address hyperinflammation and cytokine storm because these aspects are not directly addressed by the standard therapeutic measures. So in cases of ongoing instability and not a rapid recovery, then adjuvant therapies like CytoSorb therapy should be considered to have their place. The challenging aspect about this is that you don't have too much of a time to make up your mind. Ideally, and I will come back to this aspect, I think every now and then in my further talk, ideally you only have 12 to up to 24 hours for this decision making. Then let's have a thought about the therapy goal. Of course, still many want the final outcome, the final mortality benefit, at best shown in a large multi-center double-blinded RCT. It's understandable that mortality is an interesting outcome, but we have learned by that many failing RCTs that it's not the ideal endpoint really to assess the efficacy of a single intervention. I would like to quote Jean-Louis Vincent, who also recently stated and asked, is it reasonable to try to decrease mortality with a single intervention? Probably not. That's why I think we should go more to proximal outcomes, endpoints, like the influence on organ function or dysfunction. And here, CytoSorb has a very nice clinical effect in regard to shock reversal, in regard to hemodynamic stabilization of these refractory patients. So it can serve as a bridge to recovery if, of course, proper source or trigger control is present. As said, CytoSorb can't be any causative therapy, but even with a proper source control, you still might have this hyperinflammation as an independent problem to be addressed specifically, and then the combination can bring the patient towards a recovery. If proper source control is not given, it might still be fair to use the adsorber rather in a kind of to prevent further deterioration, rather in a kind of bridge to destination. But one should be aware that final recovery is only working with a proper source control. So to have an idea about a realistic therapy goal is also very much important. Bridging to destination, as shown in this case report, when there was a bridging to surgery, is a fair approach as well, but you should know about the limitations. When you start, you should start early. That's not a surprise. That's not really new. Septic shock is a medical emergency. Resuscitation should begin immediately. That's a best practice statement I think everyone would agree with. So what does this mean in regard to CytoSorb therapy? There is a certain delay because first you start with the standard therapy, then to see whether or not the patient is properly responding. Some impact of the therapy delay was nicely suggested by this analysis from Klaus Kogelmann and others. He evaluated 200 patients in regard to the impact of therapy delay on outcome, on mortality at day 56. And he could show that every additional hour in CytoSorb delay increased the odds of mortality by 1.5%. So therapy delay was the time between start of standard therapy until start of CytoSorb. So 1.5% doesn't sound that dramatic, and I wouldn't overdo it saying it's really every single hour counts as it does in antibiotic therapy, but it does emphasize that you really shouldn't wait too long to still have good chances for therapeutic success with the therapy. What does this mean if there's not any other circuit available? Because it's understandable, quite comfortable and safe to simply integrate the adsorber into an existing renal replacement therapy circuit. However, especially when you start early, there might not be another circuit present at that time. And then consequently, you should set up a circuit of its own just for the CytoSorb adsorber. So use CytoSorb in a standalone approach. This was nicely supported by the ATKI work group in their consensus when they stated that extracorporeal blood purification for immunomodulation can be considered in patients as a standalone approach if kidney support is not required. So in other words, you shouldn't wait for the AKI. Various renal replacement therapy machines enable a hemoperfusion mode. However, in a couple of weeks, we should also be able to provide a dedicated hemoperfusion machine for CytoSorb called the Purify. If you start early, you might really make an impact also in regard to need for organ support and potentially also in regard to the ICU stay. At least this was suggested in the analysis of 100 patients from 5 centers in the US, all patients with COVID-19 and hyperinflammation and an ARDS that were treated according to the FDA Emergency Use Authorization. So they were all treated with VV ECMO plus CytoSorb. And in a subgroup analysis, it could nicely be shown that those patients that were treated earlier really benefited or seemed to benefit from this approach by having a significant reduction in need for ECMO therapy, in need for mechanical ventilation, and in regard to ICU stay. So the earlier, the better in this regard, but it's also about the dosing. It's not only about starting in the right patient, it's also what about my dose? Also, this aspect is nicely discussed in this ATKI consensus when they state that the optimal delivery of an extracorporeal therapy like CytoSorb is determined by factors as the time initiation, but also by the individualized patient dose. We all know that the dose makes the poison, and I was lucky to see this, that today I only had 2 espressos, so I still have a room left or space left before it becomes toxic. So, but joking aside, the dose makes the poison, but you can also have too little effect if the dose is too low. We know this from pharmacology. So we know that you need a certain appropriate dose to make a difference. And I think this is also given for CytoSorb. And again, this registry results from the US shows quite some nice signals in regard to the potential importance of a change of the first adsorber after already 12 hours, or in other words, to use 2 adsorbers in the first 24 hours. Because this was exactly the dosing regime that was applied to all these 100 patients, primarily because this was required by the FDA. As I said before, those cases were all under the Emergency Use Authorization. So the FDA defined the way how the adsorber had to be used. And this was exactly in this setting, 12 hours, 12 hours, 24 hours, 24 hours. And the outcome of this approach was a very good one, which is, of course, not the final evidence that this is due to the dose, but it's a very strong signal with this very good outcome that an intensified dosing, especially on the first day, seems to be very beneficial. So hit hard, but also hit early, or in other words, hit early, but also hit hard. And this is nicely summarized in a new book, or a new book chapter of a new book, which is called The Adsorption, the New Frontier in Extracorporeal Blood Purification. It's by Claudio Ronco and Rinaldo Bellomo, and it has a chapter on hemoperfusion with CytoSorb, summarizing the current knowledge on exactly patient selection, timing, dosing. And you'll find the statements or the aspects I just presented to you. So the early start, the individualized patient selection, the intense treatment, and the early change of the adsorbent after 12 hours. This is further tested in a large RCT, a multi-center RCT in Germany called the PROCIS RCT. That's prospective, randomized, multi-center, single-blinded controlled study with approximately 20 centers in Germany. The PI is Professor Kluge from Hamburg-Eppendorf. And it's, of course, registered under clinical trials. And the primary endpoint is not mortality, it's percentage change in administered noradrenaline 24 hours after start of the intervention. So addressing organ dysfunction or stabilization of organ function with the adsorber. And the need for RCTs was also discussed between Michael Ioannidis and Marlies Ostermann, but Marlies also stated we also need real-world evidence, we also need registries. And this is also a reason why a large Cosmos registry has started a couple of months ago. It's a kind of successor of the Jena registry, which had to be stopped 2 years ago. It's including a variety of critically ill conditions or indications. So it has a very nice database that can capture various use cases. The idea is to enroll around 3,000 patients in the next 10 years. Clinical data will only come from the standard clinical care, with one tiny exception, that there will be a telephone follow-up call after around 90 days. The PI is Dr. Ricard Ferrer from Barcelona in Spain, and we will surely learn more about this registry and learn about first interim analysis of the first patients in the coming year. And of course, years as well, with more and more patients being included in this registry. So let's have a look at some recent clinical data from various fields of use. Gabriela Bottari has recently published a very nice study of CytoSorb in pediatric septic shock. She managed to include 17 patients in this setting and compared this to a historic control group of 13 patients that came from the EuroECID database, and she could nicely show a by far more pronounced hemodynamic stabilization in the CytoSorb treated group, positive effects on cardiac contractility, and a trend towards lower mortality. Next to this, again, the therapy was very safe also in this very sensitive patient population. Also, the technical aspect of running an extracorporeal therapy in those small patients was not any issue. The field of lung transplant has been covered in quite some of the recent publications. I earlier presented some analysis from Sandra Lindstedt suggesting some proteomic changes. This is another small but very nice publication, a kind of pilot study. She's currently conducting a larger RCT in the setting of lung transplant. Here, 2 patients were treated with CytoSorb during lung transplant surgery compared to 2 patients without any CytoSorb adsorber. And the idea was to reduce the nets, so the neutrophil extracellular traps, which are associated or which are thought to be associated or be responsible for the development of primary graft dysfunction. And they could show that the inflammatory state was lowered in the patients treated with CytoSorb. The nets were lower, the neutrophils were lower, and also clinically, the graft acceptance was better in those that were treated with CytoSorb in comparison to the non-treated transplants. There were not any acute rejections in the CytoSorb patients and quite some in the other 2. Small patient numbers, but still very nice signals. And more data from the field of lung transplant come from Italy, when they looked at CytoSorb during ex vivo lung perfusion. So they had overall 54 EVLP procedures, 21 with the adsorber, 33 without, and the comparison that showed a significant decrease of various inflammatory mediators and also a lower in-hospital mortality in 1 year death rate in those patients that had received CytoSorb treated lungs. So this study is suggesting not only the safety of this approach, but also the efficacy in regard to reducing the levels of inflammatory mediators during EVLP. And another very nice publication is coming from Italy, focusing on patients with more or less heart failure. So it was a mix of indications. There were 359 patients that were treated in San Raffaele in Milan, cardiac arrest or refractory cardiac arrest, cardiogenic shock, post-cardotomy shock, and other indications. And again, the CytoSorb treatment was associated with a reduction in laboratory parameters of shock and reduction, improvement of the vasoactive inotropic score. So again, support of hemodynamic stabilization. From a technical perspective, it was interesting that here the CytoSorb adsorber was either integrated in the ECMO circuit, directly into the ECMO circuit, or used as a standalone approach in a hemoperfusion-like setup. Also, this worked quite easily and safely. As an anticoagulation, they used in most of the cases bilirubin. So that's also an interesting information that this seems to be working as well to run this anticoagulation with bilirubin together with CytoSorb in hemoperfusion or ECMO. And last but not least, another publication on CytoSorb in VA ECMO, a lot smaller, of course, 16 patients, 9 were treated with CytoSorb, 7 as a kind of control standard of care. Again, a direct integration of CytoSorb into ECMO treatment for only 24 hours, but still there was a hemodynamic stabilization seen in those CytoSorb patients. And for the first time, there was a higher urine output reported. So it's suggesting that there might also be effects on kidney function, on urinary output, at least based on those results. Another important overall message when we look at those fields and at those publications is that there's a lot more than just septic shock. I think sometimes the therapy seems to be very much restricted to the use in septic shock, but when we look at pathophysiology, we know that a cytokine storm, a dysregulated immune response, can also occur beyond infection. It can also occur from sterile triggers via the damage-associated molecular patterns, and this response can be quite similar. The problems can be quite similar, and the clinical picture in the end can be very much the same. So in this regard, there's a lot more than just a septic shock, which might end in using CytoSorb in a reasonable manner. I think this shouldn't be forgotten. And some words also on a very recent meta-analysis that was done in Hanover. I think the authors put really quite some efforts to put various studies together and analyze them in regard to effects on mortality. You might discuss whether it's the most reasonable approach to really combine those different indications and analyze it all at once, because they were quite different. There were use cases on intraoperative use versus postoperative use for many days. There were sometimes even patients included without any hyperinflammation. So the pathophysiology, I think, was to some extent at least quite different. But anyway, I would not object to the overall conclusion that there's no evidence for a positive effect of the CytoSorb adsorber on mortality to date. I would agree with this. However, I have a bit of a problem with the further conclusion saying here that justifies its widespread use in intensive care medicine. Nicely, Federico Pappalardo from Italy has responded to this with a letter to the editor that was recently published in Crit Care as well. And he brought up, I think, quite some nice points I fully agree with. First of all, he said that mortality, and I've said this a couple of times earlier, is likely not a suitable study endpoint for an adjunctive therapy like CytoSorb. Or asking in Jean-Louis Vasson's word, is it reasonable to expect a decrease in mortality just by a single intervention? Then no proven mortality benefit does not justify the recommendation to not use the therapy. We have that many therapies, unfortunately, that have no proven mortality benefit. So if this would be a prerequisite, there would hardly be anything left to treat the patient at the bedside, unfortunately. Then Federico nicely emphasizes the limitations of some included studies. There was a lack of patient population enrichment and kind of unsuitable design, high heterogeneity. And again, this is not meant as a criticism to the authors, it's just reflecting this evolution in a better understanding what optimal therapy management for CytoSorb should look like. I think we have had quite an evolution. Everything else would be a shame if we wouldn't have a better knowledge now back than 10 years ago. But this has also been taken into consideration when you analyze all the studies who might not have had this proper therapy management, because that's important as with every other therapy. So he concludes that generalizations and simplifications are not really helpful to improve knowledge and also patient care. And in this regard, I'm tempted to quote H.L. Mencken, who nicely said, for every complex problem, there is an answer that is clear and simple. However, this is also wrong, this answer. So complexity is something to be dealt with. And I think I leave it with this and would like to summarize the talk. When we look at the current data, and knowing that there will be more data coming from the large RCT and the Cosmos registry, I think we see a nice evolution, and we have a certain understanding of not only therapy management, but also about the clinical effects when CytoSorb is used properly. We have shown that it's possible to support the rebalancing of the immune system to significantly attenuate hyperinflammation without compromising long-term immune function. The major clinical effect is hemodynamic stabilization and vasopressor reduction. However, we have more and more signals towards an improved endothelium integrity, improved lung function, improved microcirculation. It's also a very safe therapy. This safety has been shown in various RCTs. It's also very nice, let's say, given or explained by the size selectivity, by the concentration dependency as important features, also by the high biocompatibility of the beads, and the safety is further supported by real-world data, by the registry, for example, from Jena. This was including 1,400 patients in the final analysis, and also these results were suggesting the safety of the approach, and also the mentioned CTC registry, including 100 patients with a very strict monitoring, because this was under FDA surveillance, so to say, with a very strict also safety monitoring, does further support the very favorable safety profile of the device. And there are other publications who are in this direction. An often heard concern is, understandably, what about unwanted drug removal with extracorporeal therapies like CytoSorb? That's, of course, in principle to be taken seriously. And I think there are also quite many data available in this regard, but there are also quite many data available that are rather reassuring, at least for quite some substances. Here, for example, Gabriela Bottari, again, did a very nice work when she looked at the impact of CytoSorb as well as CRT on antimicrobial drug removal in critically ill patients. And he could show that, for example, amikacin, meropenem, and ceftazidime are by far less reduced. So there's a lower clearance by CytoSorb than compared to the CRT. This was not given for levofloxacin. So it doesn't mean that CytoSorb is always the nice guy. That would, of course, be too good to be true. And we, for example, also know for vancomycin that there might be a certain removal, and this should best be compensated with 500 milligram extra. However, when you sometimes hear that the adsorber has the high risk of generally removing antibiotics, that's not true either. We have quite some data already, and quite many speak for not really any relevant impact. The current knowledge is also summarized in overviews like this. We provide this in our new CytoSorb guide. It's also based on a very nice review article I can only recommend to read. And here we see or present the current knowledge. That's, of course, a living list. We will include new information like the information I just showed you from Gabriela Bottari into this. And we have other very nice data that were recently published on the impact of immunosuppressants. This was a sheep model that was investigating 7 classical immunosuppressant drugs, and the results are also very reassuring in regard to the safety. There was a negligible clearance for prednisolone and basiliximab. The other substances had some certain clearance by the adsorber, but the maximum absolute adsorbed amounts were less than 5% of the daily administered dosage. So not really that dramatic, so that the conclusion, again, was it appears to have a limited effect on the clearance of the tested immunosuppressive drugs. Ideally, you should always do a drug monitoring because you have various reasons of an altered pharmacokinetic, but I think it's fair to say that in quite many substances, not to say probably the majority of the drugs tested so far, CytoSorb didn't seem to have a larger relevant clinical effect. And with this, I'm at my final summary. I think CytoSorb hemoadsorption has shown with enough data to provide or to work as a safe and effective tool to reduce elevated levels of cytokines. So again, as Marlies Ostermann said, technically the cartridge does work, it's doing its job. For a clinical impact, of course, proper therapy management is decisive. And what does this mean? Proper patient selection, having a good understanding of your goal, timing, dosing. The patient selections are those that are an early refractory vasopressoric shock when CytoSorb is used as an adjuvant therapy. The goal is support of organ function, shock reversal, and rapid hemodynamic stabilization. The timing is hit early, ideally within the first 12 hours after start of standard therapy, but also hit hard with 2 adsorbers on day 1, changed every 12 hours, and then continue until stabilization. In the end, it's of course a very individual patient decision and patient management, and you might need a bit more adsorbers in one patient and less in the other, but that's I think the major aspects to be taken into consideration when you use the adsorber in this environment. And with this, I'm at the end of my presentation. I hope you enjoyed this update. There's a nice development over the years, a nice growing body of evidence. So we will definitely learn also more in the coming months and years about the CytoSorb therapy, about potential improvements of therapy management and other aspects. I'm open for your questions, and I thank you very much for your attention. How can the selectivity be explained in terms of molecule size? It is selective in regard to the size because you have to be small enough as a substance to enter through the pores on the surface. And there the threshold is at around 60 kilodalton. So that's definitely a kind of selectivity. The other selectivity is the hydrophobic nature, which is required. Hydrophilic substances small enough can easily enter through the beads, but they will not be able to stick to the surface. So hydrophobicity is one criterion, size is another, and the concentration is also important because the high removal efficiency is only given in elevated concentrations. As I said, this is addressing the principal target, the rebalancing, and it's preventing that you remove a mediator completely from the blood, which I think would also not be really productive, not to say even harmful. So I hope that this is kind of answering your question. If you have any further questions that come up tonight in the next days, you can also contact us via our hotline, or you'll contact the responsible salesperson in your area or distributor and let us know then. If you want to generally make yourself more familiar with what's available for CytoSorb therapy, you can check out our literature database accessible via the website, and you can filter according to various tags, or have also use a free word search. And in the media center, you might also have the chance to listen to this or to other webinars again in case you want to. And if then not any other question or concern or critics come up, I thank my colleague for the support in the background, and also my other colleague for the technical support, Attila, and I wish you all a very nice evening, day, again, from wherever you were joining, and hope to see you next time when we have another webinar on CytoSorb therapy. I think this time in rhabdomyolysis or liver failure. I think it was put in the chat by my colleague. So thanks for your time, thanks for your interest, and take care. Bye.